Hello everyone. As you all know, my name is Christine Van Dillen, and today we're going to be reviewing pre-hospital sepsis recognition due to the fact that we're going to be introducing some new monitors on the trucks, as well as a new protocol, the sepsis protocol. First of all, our objectives today will be to understand the physiology of sepsis, understand early goal-directed therapy, understand the importance of lactate, and the importance of end-tidal CO2. So throughout this lecture, we're going to review a case. This case is going to be the I'm all congested up here, pointing to his nasal cavity. This is going to be a 53-year-old African-American male. History of present illness is that for about a week, he's felt congested in his chest, he's had a productive cough of green sputum, and he's had what he has felt like fevers and chills, as well as lack of eating, no appetite. His past medical history includes seizures and thrombocytopenia, and his social history includes that he's a heavy drinker and he smokes about a pack a day. When you walk into the patient's house, you notice that it looks like a well-appearing 53-year-old gentleman. He's complaining of cold symptoms. Why does he need EMS? What is some key information that you need to know? Now think about this for a second. He looks good. But he says he's been congested, he's complaining of fevers and cough with sputum. So here are his vital signs. Obviously, that's the first thing you want to look at. And with the concern of the fever that he complained of, you went ahead and took his temperature. Obviously, it's elevated, 101.6. His blood pressure is low to borderline low. His heart rate's elevated at 135. On room air, he's 86%, which is obviously abnormal, and his respiratory rate is 32, which is elevated. So with a cough, fever, documented fever, objectively, lack of ability to keep his oxygen saturation up, as well as a fast respiratory rate, you're concerned about an infection, likely in the lungs. So here's his physical exam. He's in mild respiratory distress. He's got some jaundice in his eyes. His mucous membranes are dry. And he also has some decreased breath sounds in the left base. Dull to percussion and rhonchi in the right middle lung field. His belly's non-tender and non-distended. He does have good bowel sounds. And his extremity is normal. He's moving them all, good pulses, no rash, and he's easily able to arouse, but he's pretty tired. Talk a little bit about percussion, just because I mentioned it in the physical exam. You can do this. This kind of helps you identify a consolidation without an x-ray, so I thought this may be interesting to you. You can lay your left hand on the back of your patient with the left middle finger just between an intercostal space between the ribs. Then you take your right middle finger and you tap on your own left middle finger between the two joints, as shown here in the picture. You compare the both sides, and if you hear a resonance bilaterally, this is normal. If you hear a dullness on one side in comparison to the other, this is likely consolidation due to pneumonia. It can also be an effusion or any type of abscess or a mass, but keep that in mind. The initial management is IV access, fluid resuscitation, supplemental oxygen, a cardiac monitor, and once he gets to the emergency department, we would want to do labs, cultures, a chest x-ray, and antibiotics. Obviously, again, in the emergency department. So how sick is this patient? This is one of the things we're going to talk about. That is Sir William Osler. In 1904, he noted that, except in a few occasions, the patient appears to die from the body's response to infection rather than from the infection itself. To talk a little bit more about this, there's a continuum of infection to sepsis or septic shock. The infection is any microbial insult that results in an inflammatory response such that otherwise sterile tissue is invaded by microorganisms. This can be a bacteria, a fungus, viral, anything of that sort. Shock is the failure of our circulatory system to be able to maintain adequate organ and tissue perfusion, which results in cell dysfunction and death, making the patient much, much sicker. Who is at risk? Immunosuppressed patients, These are patients with cancer who are on chemotherapy, patients on steroids chronically, rheumatoid arthritis patients, HIV patients who are non-treated, anyone with a recent surgical procedure, anyone with the presence of an indwelling foreign body. This includes a Foley catheter, a PICC line, a central line, a port, even if it's a central port that a dialysis patient has, if it's an external fixator for any type of orthopedic procedure, or even a peripheral line from a nursing home patient that's left in for a long period of time. Dialysis patients in general are high risk. Their immune system isn't where it needs to be with those who are not on dialysis. And patients with multiple comorbidities, patients with CHF, diabetes, COPD, all these, I know many of our patients are these patients, or even patients who have been paralyzed, who are bedbound, are at high risk as well, especially with decubitus ulcers. Concerning infections include pneumonia, urinary tract infection, cellulitis, an abscess, bacteremia, intra-abdominal infections such as appendicitis, diverticulitis, even there can be infected renal stones, cholecystitis with an infected gallstone, perforated ulcers, or even peritonitis for whatever reason the peritonitis may occur. To talk a little bit more about sepsis pathophysiology, first starts the infection. You see bacterial, viral, fungal, or parasitic infection that invades the body. This causes inflammation. The body increases coagulation and decreases fibrinolysis. And this, as you can see in this microscopic picture, causes some endothelial dysfunction and microvascular thrombosis. And due to these thromboses, you see hypoperfusion and ischemia, which leads to acute organ dysfunction. In order to recognize this and to better quantify what we're looking for in the field, we start out with what's called SIRS criteria. SIRS stands for Systemic Inflammatory Response Syndrome. The SIRS criteria include a low temperature, less than 96.8, or a temperature greater than 100.4, a heart rate greater than 90, a respiratory rate greater than 20, or a PCO2 less than 32, a white blood cell count less than 4 or greater than 12, and the reason I bring this up for us is because we do have patients who are coming from a nursing home who may or may not have a white blood cell count, and you can use this if you have it. If you don't, obviously it's not an issue. The next step in the continuum is sepsis, and this would include those who have 2 SIRS criteria, at least 2, and have a source of infection. Let's say the patient complains of pain when they urinate, and they have a fever and they have a elevated respiratory rate. Or let's say like our patient had a fever, elevated heart rate, borderline low blood pressure, and an elevated respiratory rate. So source of infection would be pneumonia with him. Again, suspected or confirmed infection with 2 or more SIRS criteria. Just to talk a little bit more about what you can see causing some of these criteria. There's other things that can cause the SIRS criteria. There's trauma, burns, pancreatitis, and there are those who have an infection, an obvious infection, that don't have SIRS criteria. So the infection bubble here is those with an infection who don't have SIRS criteria. Then the SIRS bubble are those with the criteria without an infection. And then when they have an infection and SIRS criteria, that's the center where they cross, and that's sepsis. Again, bacteremia is inside the sepsis and the infection bubble. And then as you can see, there's the viral fungus parasite that's in the sepsis infection category as well. So bacteria do tend to cause sepsis more, secondary to some of the effects that they have when they enter the body. They have endotoxins that cause more inflammation and things such as that, but all the other infections can also cause sepsis as well. When you have severe sepsis, that's the next step of the continuum where you see organ dysfunction. This can be elevated creatinine or kidney function level, elevated INR or coagulation level, an altered mental status, an elevated lactate or hypotension. you may want to say, how does this help us? We don't have a creatinine, we don't have an INR. Well, you can see altered mental status, lethargy, fatigue, confusion. You can see decreased urine output, which would correlate with a dysfunction of the kidneys. You can see hypoxia or tachypnea in concerns with respiratory depression. And then obviously you can see hypotension, which we'll talk about a little bit more in a second. This a little more clearly identifies acute organ dysfunction in the different categories. Again, there's altered consciousness with reduced GCS. There's tachypnea, where the patient may require mechanical ventilation with an elevated PEEP. Liver enzyme elevation or jaundice. Jaundice is definitely something that you can see in your patients. And then as well as a low pH with a high lactate, which we will talk about in a second. We will be using the lactate monitors as part of our evaluation, but we won't be using that as part of our decision-making process due to the level of research that we're at right now. Another sign that a patient is having some organ dysfunction is tachycardia and low blood pressure, requiring fluids and vasopressors. Decreased urine output, as we talked about previously. And then there's also changes in labs, which we will recognize in the emergency department and not as important in the field. With cardiovascular system in particular, we see manifestations, tachycardia, hypovolemia, myocardial depression, decreased cardiac output, vasodilation, and hypotension leading to shock. And so what you'll see here, high heart rate, low blood pressure. Again. You can also see EKG changes because when the heart's being stressed, you can see some ischemic changes. Pulmonary manifestations, you'll see tachypnea, fast breathing, acute respiratory failure, respiratory rates greater than 20. This specifically says arterial carbon dioxide levels of less than 32 with the tachypnea. But this is particularly mentioning the arterial level, which we were having an end-tidal level, which is slightly different but does correlate. And you can have increased PEEP requirements on mechanical ventilation. And so what this means is if you're bagging up, let's say the patient is in need of intubation, you intubate the patient, you're bagging them with the bag, and you start to have any type of concern, you take the bag off and you suction, you've lost that natural PEEP because as you're bagging the patient, that circuit is closed. It's able to continue to hold the pressure and actually elevate pressure slowly over time. And that pressure helps keep those alveoli and the distal portions of the airway open. And it helps to be able to oxygenate and ventilate the patient. So this is why if you took one of these patients and you took the bag off to suction and you put it back on, you may at first be dealing with some hypoxia until you build back up that end expiratory pressure. And then on chest X-ray in the emergency department, we will see some fluffy infiltrates, as you can see here. So this is obviously bad, and this is acute respiratory distress syndrome in adults, and this is usually the after effect on the lungs of sepsis. Neurologic manifestations, this includes a mental status change. You can see delirium, coma, and this alone is an independent predictor of mortality. So if you see this, this is very, very bad and a bad prognostic indicator. Gastrointestinal manifestations, you will see cholestasis, so you'll see patients with right upper quadrant pain, jaundice, fever, and other types of liver dysfunction. You can see high glucose levels or low glucose levels, as well as elevated lactate. Kidneys, you can see renal insufficiency, so again, decreased urine output, up all the way up into no urine output, renal failure, and the patients may, when in the hospital, require dialysis. We see levels as high as elevations to the levels as high as 0.2 to 0.5 above normal, and this also increases mortality. and the urine output will be less than 0.5 cc's per kilogram per hour. This is just an example of a bad rash that we worry about with meningococcemia. You can see the petechiae all over the patient. You can see that the patient's intubated. You can see that there's multiple lines in the patient. You can see that there's a diffuse edema all over this patient, and you can see that this patient's in a comatose state. So this is just kind of the picture of someone who's septic and kind of all of the manifestations. To continue through our continuum, the next step is septic shock. And this is a combination of the severe sepsis and hypotension that does not respond to a fluid bolus. So you have the SIRS criteria, an infection, organ dysfunction, as well as hypotension. So again, we care about this because as we progress through the continuum, the patient's mortality increases. So as you can see on the left, there's no SIRS criteria. We're at a low level of 3, and with septic shock here on the right, we're at 46% mortality. And it goes up slowly over the continuum. Why is sepsis so important? Well, for example, in 2009, the Healthcare Utilization Project noted 831,000 admissions to U.S. hospitals for septicemia, 150% increase in admissions from 1999. 26% died, which is a 3% increase in mortality, and a 200% increase in hospital charges. So it's causing life and money. So again, we don't want people dying, and we don't want to pay money. Why is sepsis important to us? Well, here in Florida especially, we have an increasingly aging population and an increasing lifespan for the patients with severe medical conditions because we're learning ways to treat them, we're causing more immunosuppression with our treatments, and so our population of immunocompromised patients is increasing. And there's an emergence of multi-drug resistance organisms with MRSA, VRA, and all these things. So it's a big problem, and it's getting bigger. Early interventions in medicine. This is something that we've been doing for quite a while that I think that we all understand very well, and this is along those same lines. So acute MI, we always say time is muscle. There's ACC and AHA guidelines for STEMI. Door-to-needle time for initiation of fibrinolytic therapy should be achieved within 30 minutes, and door-to-balloon should be kept under 90 minutes. This is a standard we have for heart attacks. For stroke, time is brain. The ASA, IV TPA is strongly recommended within 4 hours of onset of ischemic stroke. In trauma, we have the golden hour. Lives of severely injured people can be saved if treated by trauma specialists within the first hour at a trauma center. This is why we have trauma alerts. This is why we have helicopters. So this is something we need to think about doing with sepsis because actually sepsis affects more people, is starting to affect more people than even STEMI, stroke, and trauma. So we can make the difference by recognizing these patients early and making sure they get treated seriously early on in their stay in the emergency department and hospital. There was an emergency medicine doctor named Dr. Rivers who in 2001 introduced early goal-directed therapy. He did prospective trials having shown early aggressive intervention decreases mortality up to 35%. It leads to an increased 1-year survival after discharge, and many trials have reproduced these findings. Here is some. And here's another page, just to show that this works. So when can we intervene? This is where we intervene. We recognize that the patient has SIRS criteria. We use a sepsis protocol. We can identify a possible infection. We don't need to diagnose this infection. This is not important. But it does help us to recognize those patients who are sick, when to use the protocol, how to treat them, and when to sepsis alert them, which we're going to talk about in just a second. With our sepsis protocol, we need to identify the appropriate patients. These are patients with SIRS criteria. Heart rate greater than 90, respiratory rate greater than 24, temperature greater than 100.4 or less than 96.8, white blood cell count greater than 12 or less than 4, if available from a nursing home. And again, 2 or more of these criteria use the sepsis protocol. These patients are septic. Again, you might ask, what if a young child has the flu? What if someone's hungover or drunk? Yes, there are other things that can cause these vital sign changes. Alcohol intoxication, trauma, stroke, dehydration, pulmonary embolism, GI bleed, influenza. I could go on and on. But if you put a patient in the sepsis protocol, even if you call Sepsis Alert and the patient is not septic, what happens then? It's not a problem. All this is going to lead to is faster care and better care for the patient. So we are expecting to have false positives, and we are okay with that. As always, with all patients, you want to start out with BLS and ALS care. So make sure the airway is patent, apply oxygen if needed, monitor vital signs, obtain an Acute check, and then move on to advanced life support with advanced airway and ventilatory management if needed, perform cardiac monitoring, obtain a 12-lead EKG if chest pain or an angina equivalent is present, establish an IV. Hydrate. This is important with these patients. If your patient is hypotensive with a systolic blood pressure of less than 90, administer a 500 milliliter normal saline bolus and repeat as needed, and increase the blood pressure to at least greater than 100. If the patient continues to be hypotensive after a 2,000 milliliter or 2-liter bolus of normal saline, then continue IV hydration while you start to administer dopamine to help improve pressures. If you can get 2 IVs on these patients, that would be ideal. Call a sepsis alert if this is present. If you're hydrating this patient, they continue to be hypotensive, this is a sepsis alert. What other reasons can you call a sepsis alert? Identify patients that meet the SIRS criteria, along with at least one sign of severe sepsis or septic shock. So, end organ damage. That can be a patient with 2 SIRS criteria and altered mental status, poor capillary refill, decreased urine output, hypoxia or respiratory failure, or sustained systolic blood pressure less than 90. Any one of these. It does not have to be multiples of these. If you have one sign of end organ damage, 2 SIRS criteria, that's a sepsis alert. This is an algorithm which we were going to make available to you to help you decide who would be in these categories. So we're going to go through this algorithm one more time. Patient with suspected infection. Does this patient have 2 or more SIRS criteria? If they do, you initiate care via the sepsis protocol. Is the patient hypotensive? If yes, call your sepsis alert. Hydrate and go further through the sepsis protocol, which we'll talk about again in a second. Let's say the patient is not hypotensive, but does have signs of end organ damage. Again, altered mental status, decreased urine output, respiratory hypoxia, poor capillary refill. Call a sepsis alert. Administer hydration if needed, add dopamine. Now we're going to talk about the more innovative research portion of this protocol. So, the identification and use of lactate monitors in the field remains a new and innovative idea across the nation. And other EMS agencies are already using lactate monitors. But this is not standard of care yet. So what we want to do is prove that pre-hospital identification further improves outcome. So what we'd like you to do is obtain an end-tidal CO2 level early on in transport and obtain a lactate level and document this in the EMS Pro under the Interventions tab, but do not use this level in your decision-making process to initiate a sepsis alert and blind your emergency department physicians to this number. Why? Because again, this is research. Bottom line, can't use the number to make the decision, and you can't give the number to the ED physician. They can get their own lactate level, but all we're doing at this point is obtaining the levels and documenting them and reviewing them later to see the importance, significance, and outcome changes. This is the monitor we're going to use. It's called the Lactate Scout. It's very similar to an Acute monitor. It's a small handheld monitor where you place the strip into the end. There's an arrow which end goes in first, and then you take blood and you put it into this end of the strip, and it goes in as it's collected. It'll start to analyze the blood, and then you'll get a level. It takes 5 to 10 seconds, very quick, and you just All we want you to do, again, is document that in EMS Pro under the Interventions tab. Just so that you know, we have received a grant for these lactate monitors and would like to closely track these cases. So again, make sure, use the sepsis protocol, use the Interventions tab, and please put these levels, the lactate and the end-tidal CO2 levels, under the Interventions tab. What is going to happen when you go to the hospital with Sepsis Alert? So you're going to be met in the room by the sepsis team, which will include a nurse and a physician, possibly physicians from upstairs. If they don't come down immediately, they will be coming down very soon, and they will help decide the early appropriate antibiotics, continue your aggressive resuscitation that you've started with fluids and pressors, and do some diagnostic testing to specifically identify the source, and then determine the appropriate level of care needed. Does this patient need to go to the operating room? Is there an intra-abdominal abscess? Can this patient go to the floor? Sometimes these patients have a cellulitis that, maybe we fluid resuscitate them in the emergency department and they can't go to the floor. But many of these patients end up intubated with a central line in the ICU, and that's something that needs to be determined early on and taken care of. Basically, we want to increase awareness and improve patient outcomes. When you identify these patients, they will receive early intervention. We will stop the progression through that sepsis continuum, which will decrease morbidity, mortality, and healthcare costs. So you may stop a patient from requiring dialysis for the rest of their life. You increase their quality of life. And what specifically, why do we even care about the lactate? Lactate is a validated marker of poor outcome in sepsis patients because elevated lactate precedes vital sign changes and evidence of organ dysfunction. It can identify patients who are sick versus not sick if their vital signs have not caught up with their level of response to the infection. These patients benefit from aggressive resuscitation. For an example, this is a study from Shapiro et al., where you are looking at lactate levels versus mortality rate. And as you can see, a 0 to 2.4 has a 5% mortality, a lactate level of 2.5 to 3.9 has a 10% mortality, and a lactate level greater than 4 can have up to a 28.4% mortality. So again, lactate greater than or equal to 4 translates to a mortality greater than 30%. And when you're placing an IV, you could just use the blood obtained in the process of getting the IV, like many of you do for the Acute, to place on the testing strip and put into the Lactate Scout machine. And you can use blood that's stored in a syringe if the first responder crew had some excess blood. Ideally, you would use the blood that was first obtained. Also, if drawing from a peripheral vein, make certain that the tourniquet isn't on for a long period of time, because this can falsely elevate the levels. So back to our patient. His new oxygenation is 91%. His respiratory rate is still 36. Heart rate is still elevated at 130, but his blood pressure is 138/74 because the amazing prehospital crew gave him 2 liters of fluid. His labs on arrival to the emergency department are found to be 5.3 is his white blood cell count, his hemoglobin is 15, his platelet is 19. His basic metabolic profile shows that he's slightly hypokalemic, or his potassium is low, but his creatinine is elevated at 2.0, which is a concern. His INR is also elevated, which is a concern that he may be having some liver dysfunction, as well as his total bilirubin, and his lactate level is 8.4. So this person is sick. His chest x-ray also reveals left lower lobe pneumonia, which you caught with your percussion. So the 8.4 shows that he is in cryptic shock. Again, this patient is very sick and has a very high chance of mortality. So he ends up getting a cefepime 1 gram dose IV, and he's intubated due to his hypoxemia and his altered status to help decrease his work of breathing. He's diagnosed eventually with streptococcal pneumonia. He's weaned off vasopressors at day 5. He's self-extubated at a hospital day 5, and he's discharged home on hospital day 10. So when these patients are recognized and treated appropriately, they can go home with a good quality of life. So in conclusion, early recognition is key. Early goal-directed therapy reduces mortality, early antibiotics reduce mortality, and we must work towards this early recognition. Thank you.